Welcome to today's Explainer. I'm so thrilled you're here with us. If you're the kind of person who loves getting straight to the facts with a clear visual structure, well, you're in exactly the right place. Today, we're putting a spotlight on a commonly misunderstood but absolutely crucial uterine condition. We're going to cut right through the medical jargon, look at the actual data, and really understand what's happening inside the body. It's fascinating stuff, so let's jump right in.
Endometriosis or endometrial hyperplasia. These two medical terms sound incredibly similar, right? And because of that, patients mix them up all the time. You've probably seen discussions online or maybe even had conversations yourself where these two totally distinct diseases are just lumped together. But treating them as the same thing, that's a huge misconception. And honestly, it can cause a lot of unnecessary panic. So our goal today is to clear that up completely and give you a crystal clear understanding of the exact difference.
Here is our roadmap for today. Number 1, similar but different uterine diseases. 2, a precancerous stage. 3, accelerator and brake. 4, testing and diagnostic flow. And finally, number 5, surgery or medication.
Section 1. Similar but different uterine diseases. Clearing up the terminology. Okay, let's dive into this and bust the biggest myth right off the bat. To really get a grip on the disease, we first need to understand the healthy anatomy. The endometrium is the inner lining of the uterus. You can think of it as functioning kind of like a protective bed for a baby to grow in. Naturally, a woman's body prepares this cozy environment for a potential pregnancy. And to make it welcoming, the body actively works to thicken this inner lining. That thickening? It's a completely natural, beautifully orchestrated, and honestly, a vital biological process.
But here is where the two conditions completely diverge. Endometriosis is when this lining-like tissue forms in the wrong place entirely, literally outside of the uterus, attaching itself to other organs in the pelvic region. Endometrial hyperplasia, on the other hand, which is what we're focusing on today, happens inside the uterus. The word hyperplasia essentially just means overgrowth. So endometrial hyperplasia is a condition where that internal bed, that inner lining, gets dangerously, excessively thick. Just to recap, two totally different locations, two completely different conditions.
Section 2. A precancerous stage. Understanding the real risks. Let's slow down for a second and take a look at how this internal overgrowth actually translates to real medical danger.
Now, endometrial hyperplasia can actually act as a precancerous stage. When that internal uterine lining over-thickens, it becomes a potential stepping stone to actual endometrial cancer, which you might also hear called uterine cancer. And because these two things are so closely linked biologically, they share identical warning signs. The absolute main red flag you need to be aware of is irregular bleeding or unexpectedly heavy menstrual bleeding. Basically, if the lining is growing out of control, the body's going to signal that something's wrong, most often through bleeding outside of a normal cycle.
17 to 50%. Wow, right? So what does this massive range actually represent? Well, within endometrial hyperplasia, doctors use different classifications based on how abnormal the cells look when they check them under a microscope. The absolute most severe form is called complex atypical endometrial hyperplasia. When patients are diagnosed with this specific severe form and they undergo surgery to remove the uterus, doctors discover that between 17 and 50% of the time, actual fully developed endometrial cancer was already hiding inside. That is a massive percentage, and it really highlights exactly why doctors take an over-thickened lining so incredibly seriously.
Section 3. Accelerator and brake. The role of hormones. Now, what's really interesting about this next concept is the mechanics behind the disease.
You can really think of this like a mechanical process. You've got two main hormones at play here. Estrogen acts as the accelerator. It drives the thickening of the uterine lining to build up that bed. On the flip side, progesterone acts as the brake. It tells the body, okay, stop thickening the lining, let's keep things in check. Endometrial hyperplasia happens when there's a mismatch. Basically, the accelerator is pressed down way too hard or for way too long without enough brake to balance the whole thing out.
So who is actually at risk here? Because this condition is so heavily dependent on estrogen, our accelerator, anyone with prolonged estrogen exposure is naturally at a higher risk. Medical data shows us it's most commonly diagnosed in women in their 40s and 50s. A time when hormones are often fluctuating pretty wildly leading up to menopause. And perhaps most notably, just like uterine cancer, overall diagnosis rates for endometrial hyperplasia are going up. It's an increasing issue across the board, which makes understanding how we diagnose it absolutely vital.
Section 4. Testing and diagnostic flow. How doctors find it. If this is a growing issue, how exactly are we catching it? All right, There are two primary methods of testing. Step 1 is usually cytology, which is your standard screening. Think of this kind of like using a tiny brush to gently sweep up cells that have naturally fallen off inside the uterus. It's a quick, surface-level check. But if that screening comes back showing something abnormal, doctors have to move to the second procedure, a biopsy. A biopsy is a bit more intensive. Instead of just brushing, the doctor actually scrapes a tiny piece of the internal tissue. This is crucial because it allows specialists to look at the actual structural architecture of the cells under a microscope. It's only through this deeper, microscopic examination of the scraped tissue that a definitive diagnosis of endometrial hyperplasia can actually be made.
Which leads us to the terrifying question so many patients face the absolute second they hear the diagnosis. If I have this, does it mean immediate surgery? Does my uterus have to come out right this minute? Section 5, Surgery or Medication, Navigating Treatment Pathways. So the crucial point is, how do doctors actually navigate these choices?
Let's just take a deep breath here. Not all diagnoses require immediate surgery. Remember earlier when we talked about the cells getting progressively more abnormal over time? Surgery, specifically a hysterectomy where the uterus is removed, is generally reserved only for those complex atypical cases. Those are the ones sitting right on the borderline. They're the absolute closest to becoming actual cancer. For the less severe forms, it takes time to reach that critical stage. And that means doctors have a much wider window to manage the condition without rushing into an operating room.
And there is an incredibly hopeful alternative here. High-dose progesterone acts as a brake, offering a non-surgical treatment path for those wishing to preserve fertility. By medically introducing high doses of progesterone, doctors are essentially slamming on the body's internal brakes, actively halting that estrogen-driven overgrowth. I mean, this is a total game changer for younger women who still want to have children. Now, to be totally transparent, it does carry some risks of potentially developing into cancer later down the line, so it absolutely requires strict ongoing medical monitoring. But it brilliantly proves that an immediate surgical hysterectomy is definitely not the only answer. We have covered a lot of ground today, right? From debunking that terminology mix-up with endometriosis, all the way to understanding the delicate balance of your body's hormonal accelerator and brake. So I want to leave you with this final thought. Knowing the precise difference between what happens on the outside versus the inside of your uterus, how will you advocate for your next preventative screening? Knowledge truly is your best defense. Thank you so much for joining me for this explainer, and keep asking the right questions about your health.